All right, welcome everybody to today's webinar, COVID Care After the COVID-19 Public Health Emergency Ends. My name is Martha. I am the Manager of Online Education and Evaluation for MCN. And let's go ahead and go to the next slide. If I can forward. Here we go. So this presentation is offering simultaneous interpretation. So just go ahead and click on the globe icon and select the language that you want to listen to. We also have this presentation in Spanish. So if you click on your toolbar, there's, let me see, where is it here? Esther, how do you do the the sharing on this one?
Yep, no worries. So at the very top of your screen, you're going to see a View Options tab. It should be in the center of your screen. You're going to hit that menu option, and then you should see diapositivas in Español or slides in Spanish, and also Marta's slideshow presentation. So feel free to click the one that corresponds with your language of preference. Arriba en su pantalla va a ver la opción de ver opciones. Está en el centro de su pantalla. Va a escoger esa opción y abajo va a tener la opción de ver diapositivas en español o diapositivas de Marta. Puede seleccionar las diapositivas que corresponden con su lenguaje preferido.
Thank you, Esther. Let's go to the next slide. So we just want to mention that we have no conflict of interest, no relevant financial relationship that relates to this presentation, or a relevant financial relationship with ineligible companies whose products or services are related to pertinent therapeutic areas. Let's go to the next slide. And just a reminder that this presentation has been accredited for continuing education. So if you want to receive your certificate of continuing medical education or your certificate of continuing nursing education or a certificate of attendance, you are required to submit the evaluation at the conclusion of this presentation. Let's go to the next slide. And really quickly, we are MCN, and our mission is to create practical solutions at the intersection of vulnerability, migration, and health. And we envision a world based on health justice and equity, where migration is never an impediment to well-being. Let's go ahead and go to the next slide. In today's learning objectives, we're going to be familiar with the latest guidelines for COVID-19 vaccinations. We want to identify critical changes in vaccines, testing, and treatment after the end of the COVID-19 public health emergency. And lastly, describe ways in which patients with limited or no insurance can access COVID preventative and curative care. Let's go ahead and go to the next slide. And providing all this great information will be Dr. Ed Zurawesti. I want to welcome Dr. Zurawesti with us. Thank you for being with us, Ed. And we're just going to go ahead and let you take it over. So take it away, Ed.
All right, thank you very much. And boy, it's great to see such a nice crowd today. We really appreciate all of you spending some time with us. We know you're all very busy in your daily lives and work, and so we really appreciate the attendance. I'm the founding medical director of the Migrant Clinicians Network. I'm a family physician, and I'm going to be giving the clinical update today. And we always state right at the beginning that this clinical update is as of today, May 31st, the last day of May 2023. And things move very quickly in the COVID world. So what I'm going to present to you today may not be accurate a week from now, 2 weeks from now, a month from now, but it is accurate as of today. We're very cognizant of the point that we want to give the most up-to-date information that we can. So we were researching this up until just a couple hours ago. All right, next slide, please. Okay, the second bivalent booster. Who needs another booster? Well, on April 18th, a little over a month, almost 6 weeks ago now, the FDA approved a second bivalent booster from Moderna and Pfizer. And these were specifically for individuals over the age of 65, people like me, as gray hairs, and anyone who's immunocompromised. And I'm going to go into that in a little bit more detail in just a minute. Why another booster for some? Well, even though the numbers are really dramatically going down, as of a month ago, there were about 1,200 people dying every week of COVID. This last week, a week ago, there were only 247 deaths from COVID in the United States. So it's really plummeted in the last several weeks, but it's not gone. There were 247 Americans who died of this virus just the week of 5/20. And there were over 8,000 hospital admissions during that same week in the United States. And we all know that these numbers may be undercounted due to federal reporting mandate is no longer being in effect. So these numbers are getting a little bit sketchier now, although the deaths are pretty accurate. The hospitalizations are a little plus minus now. All right, next slide, please. So when we're talking about immunocompromised and elderly, I hate it when they say elderly because I'm in that category now and I don't feel elderly. I probably look elderly to all of you, but we are what we feel, right? So comorbidities increase with age and immune system is weakened. So anybody who has a weakened immune system, that individual is more prone to complications of COVID. They're more likely to be hospitalized and more likely to die from COVID, even if vaccinated. The latest CDC data does show vaccine protection wanes among elderly after about 4 or 5 months. And there are some good studies now that show even after a couple months, the vaccine wanes. So that's why we're giving another vaccine now, since the last bivalent was several months ago. It's also important to note that 75.5% of the COVID deaths are in the people over 65 and over. So we really want to make sure that those individuals are as protected as possible. So that's why the new bivalent, as of April 18th, last month, is recommended for anyone over the age of 65. The risk of severe infection and deaths dramatically declines with vaccination, even for the elderly. So you may get infected if you're over 65, if you get the bivalent vaccine, but you're very less likely to die from the COVID. Next slide, please. Well, what about younger people? Younger people are healthier individuals. They're staying out of the hospital for several reasons because of hybrid immunity. And what hybrid immunity means that either they've had some vaccination and or have been infected. So many youth now have been infected and or vaccinated. So they have a hybrid immunity and their immune system is much stronger than someone over the age of 65. They're also less likely to have any sort of comorbidities like diabetes or cancer chemotherapy, or be on a drug for arthritis or some sort of immunosuppressive type medication. But younger people still need to be vaccinated. If they haven't been vaccinated at all, they should be vaccinated. Next slide, please. So what is a bivalent booster? Bivalent means it's a little of the old and a little of the new. So the first vaccine we had was a monovalent vaccine. It only had one variation of COVID, and that was the early Delta strain. Now the bivalent adds the Omicron strain to that. So you have both the old virus, the original virus, and the new virus that is infecting people now, the bivalent. So that's the Omicron specific portion makes it the bivalent. Anyone who received a booster September, the first bivalent booster came out in September of 2022. So anyone who's received a booster since September of 2022 received a bivalent booster. There are no longer any other monovalent boosters out there. So anything since September was bivalent. Next slide, please. So the FDA currently, the vaccine updates are, if you're immunocompromised, therefore, if you have anything that makes your immune system not as robust as it should be, you're on chemotherapy, you have a kidney transplant, so you're on something that immunosuppresses you, or if you have diabetes that makes your immune system not as good. If you're 5 years and older and immunocompromised, you should get another bivalent vaccine. If you already received the first one, you should get the second one. It should be at least 2 months after the first bivalent booster, and an additional bivalent dosage as needed, but no closer than every 2 months. Some people who are severely immunocompromised may be continually getting these vaccines every 2 or 3 months. And as I mentioned before, if you're 65 years of older, like myself, I'm actually going to get my bivalent tomorrow. My wife has already gotten hers. We got our first bivalent in September of 2022. So I'm at least 4 months past that first one. I'm well over that now. So it's good for me to get a second one. And I'm going to explain why I think I should get a second one. And all of you who are over 65 should get the second one. And anyone you're counseling over the age of 65 should get a second one now. Next slide, please. So the primary series and bivalent boosters, not currently eligible for any additional bivalent dose. So if you are not in that age group, over 65 or immunosuppressed, there's not a current eligibility for an additional bivalent. But that is going to change probably in the fall of 2023. And I'm going to talk about that. And maybe I'll talk about that right now. What's happening, no, I think there's a slide coming up. I'll hold off on that for right now. If you're unvaccinated, though, you may receive a single bivalent dose instead of multiple doses of the monovalent mRNA COVID vaccine. So anybody out there that you're counseling who has had no vaccinations whatsoever, even if they've had a bout of COVID, they should now receive a bivalent dose because it will help prevent severe COVID if they get a second round of COVID. It will also protect them from long COVID. So if you're counseling people who've never been vaccinated, they don't need to get the series, the primary series. They can just get one bivalent dose now. If you've had the primary series but no bivalent dose, you can still receive a single dose of bivalent. So if you've never received a bivalent, you can get this one. So only the people who got the primary series and got the first bivalent dose in September of 2022, those people do not need another dose unless they're immunocompromised or they're over the age of 65. Next slide, please. So how about children? Unvaccinated children, 6 months to 5 years, they may receive 2 bivalent doses of Moderna or 3 bivalent doses of Pfizer. So in kids, it's different. They need to have more than just one if they are totally unvaccinated. If they are going to get the Moderna, they need to have 2. If they're going to get the Pfizer, they need to have 3. If they are totally unvaccinated. Vaccinated children, those 6 months to 5 years of age, who have received 1, 2, or 3 monovalent COVID vaccines, if they've never received the bivalent in September of 2022, they can receive a bivalent vaccine. But the number of doses may depend on their vaccine and vaccination history. So it varies whether they had Moderna, whether they had Pfizer, and how many they had. So that would be up to their primary care provider or the pharmacist to figure that out on an individual basis. Next slide, please. So we have a new resource at MCN. It's pictured there. And this talks about the changes that the FDA came up on April 18th, 2023. It provides information on vaccination status, age, immunocompromised status. It goes into detail on a very nice one-pager that we revised on the 20th of April this year. So that's accessible to all of you on our website. So I encourage you to always look at our website. We keep everything up to date there. We have a great questions and answers series there that you can look up things. If you have any questions about COVID, go to our website. Next slide, please. And I have more information if there's not a next slide for me, Martha, but let's see. Next slide, please. Okay, yeah, good. Risk versus benefits of vaccination. It's kind of interesting now. We've done a pretty good job of vaccinating the people 65 and over. In fact, about 95% of people over the age of 65 have had at least 2 doses of vaccine. So that's good. Most COVID-19 related deaths are, as I mentioned before, over the age of 65. But now most of the deaths are actually in people who have been vaccinated, because most of the deaths are over 65. 95% of people over 65 are vaccinated. So that right now, and it sounds counterintuitive, the people who are dying have actually been vaccinated, but that is true because a lot of those people are really elderly, in their 70s, 80s, 90s, and have a lot of comorbidities. So even with being vaccinated, their immune system does not take up the vaccine. They do not build up good antibodies. So if they get a bout of COVID, they're towards their end of their life and they can actually die from COVID. But while this sounds like a risk, there's actually 90% reduction in death in people who have been vaccinated versus people who have not been vaccinated. So if you look at that series on the right there, it shows that most of the people, only 2 people in that series were unvaccinated and many people were vaccinated. But then if you notice, there are many, many more vaccinated people in the population than unvaccinated. So that the people that are unvaccinated have a much higher risk, a much higher percentage of dying than people who've been vaccinated. And I know this is a little confusing, and I hope I haven't confused you more. The bottom line is that if you've been vaccinated, even if you're over the age of 65, your chance of dying is much less than if you're not vaccinated. Next slide, please. Risk versus benefits of vaccination. There are some risk of vaccination, and mainly it's been for adolescent males. The risk of myocarditis continues to be a very rare but real risk. However, a serious case of myocarditis is still more likely from the COVID infection itself than actually the vaccine. And myocarditis is an inflammation of the heart muscle. If you have an inflammation of the heart muscle, we call that myocarditis. Very, very, very rare. And even if it occurs after a vaccination in an adolescent male, they usually are very short-lived and require very little, if any, treatment. And as I mentioned, it's much more common in an adolescent male to actually get more severe myocarditis if they get the COVID infection. Next slide, please. I do want to give one more information before we go to Esther, okay? And that is that on June 15th, the FDA is going to be meeting again, and they're going to be deciding whether or not what to do with the fall. And it looks like right now, because the WHO, the World Health Organization, has already come out with a recommendation for the fall. And what they're saying is we're going to have a monovalent, not a bivalent. We're going to get rid of the old vaccine because it's now extinct. We're not seeing any of that COVID anymore. It's mainly all in the Omicron variation. And it looks like what they're going to do, the WHO is going to have the XBB1 linkage of Omicron is going to be their vaccine for the future. And as I mentioned, in a couple of weeks, the FDA will be meeting and they're going to decide what they're going to do. But it looks like it's going to be an Omicron, probably an Omicron variety that's going to be coming out that will be recommended in the fall. So we're not over COVID yet. It's going to be recommended that most people get, as we do every year, a flu vaccine and also a COVID vaccine. And we may actually combine those. Nobody knows for sure now, but that's for the future. So I'm giving you just a little glimpse of the future. Okay, thanks, Esther. I'll turn it over to you.
Thank you so much, Dr. Ed. And hello, everyone. My name is Esther Rojas. I'm a project coordinator with Migrant Clinicians Network. I'm so happy to be here, and I'm so happy to see all of you here as well. We can go to the next slide. All right, so today we're going to be talking a little bit about the COVID-19 public health emergency, or the end of it. So as many of us know, this did occur on May 11th, 2022, so we're about 2.5 weeks out. And we can go to the next slide. Yep, and so this is going to be my biggest takeaway right off the bat. Like Dr. Ed Westy mentioned, there's still a significant number of people who are dying and also being hospitalized due to COVID-19. So really the end of the public health emergency, it does not mean that COVID-19 is over in any way, and it does not mean that we can let our guard up when it comes to COVID-19 in our communities. Next slide. Okay, so I did want to kind of run back the clock a little bit to the start of the public health emergency and really what the public health emergency meant for all of us. So number one, it did allow for millions of individuals to receive Medicaid, whether it was for the first time or continuing their Medicaid coverage. And this is that state and federally funded health coverage for many low-income individuals and their families. Excuse me. So it also did allow the government to provide this funding, which gave us our free COVID-19 vaccines, our tests, and some of those treatments for COVID-19. And I'm going to touch on this a little bit later. But it also did allow for that increased funding for vaccine development and also for some of that research. Okay, next slide. So now that we understand what it gave us, we also have to, oh, I think we're moving around a little bit. There we go. Okay. So what has ended as of May 11th and actually a little bit before, and we're going to see some of these domino effects happening a little bit after into the rest of the year. So what has ended with the public health emergency? The biggest thing is that we no longer have all of this money, the money that was provided for testing, for vaccinations, and also for some of those COVID-19 treatments. And some of these changes have been happening state to state. We have seen the continuous Medicaid re-enrollment process essentially come to an end, and some states have adapted that continuous re-enrollment process, but for the most part, we are no longer seeing that stay in place. So what that means is that we're going to continue seeing this divide between our uninsured individuals and those who are insured. And as many of us have seen, the termination of Title 42, and I'm going to elaborate on what that means later on. And also the decrease of SNAP benefits, which is that food supplemental nutrition insurance program. Okay, next slide. So what has the public health emergency meant for supporting our healthy refugee, immigrant, and migrant communities? The biggest thing is that that increased funding for vaccine research gave us the free COVID-19 vaccines, our free PCR tests, and our free at-home tests as well. We were also able to see a bunch of funding for organizations like our health departments, our health agencies, which offered COVID-19 mitigation and also prevention programs. COVID-19 treatments were available to all regardless of their insurance coverage or their lack of. Also that Medicaid continuous enrollment, and you might be scratching your head and saying, well, how exactly did that benefit our communities? The biggest thing that we have seen is that individuals did not have to maneuver a very complex system in order to apply for Medicaid, and they did not have to continue that yearly basis eligibility application every year. And there was also that increased food access through SNAP. Next slide. Okay, so the end of the public health emergency, and what will it mean for our communities? The first is that patients will have to continue re-enrolling with Medicaid. So we're going back to that pre-COVID standard for many states. This might not be the same in every state. I know that there's a few states who are continuing that re-enrollment process or that continuous re-enrollment, but some individuals might be losing some of their insurance coverage. So this may lead to some lower health-seeking behaviors when it comes to preventative, chronic disease maintenance, and also that acute care. There's also that increased cost for COVID-19 vaccines, limited access to COVID-19, to free COVID-19 vaccines, and no or limited access to at-home tests. Additionally, the treatment in hospitals that I had discussed earlier will no longer be free. There is instances of emergency coverage being offered to uninsured individuals, but this will vary from state to state, and it does vary from hospital to hospital as well. And of course, that lower food benefit, which ultimately will impact our communities as a whole. Next slide. Okay, so Title 42 I had mentioned. So this is that really old, arcane, rarely used provision of the Public Health Services Act of 1944, which we know as Title 42. So essentially it gives our federal government the power to deny people and goods into the country on the basis of stopping our communicable diseases from spreading, and COVID-19 was the reason why. So since 2020, we have, or I guess the US government has had this authority to expel migrants at a rapid pace and also suspend the right for asylum seekers. With Title 42, of course, there has been an influx of asylum seekers, which has ultimately put some stress on our border agencies as well. Next slide. Okay, so how can we continue accessing some of that health coverage? Individuals on Medicaid will have to continue re-enrolling on a yearly basis. So we're seeing this a lot, that individuals are receiving those notices in the mail or via email regarding their Medicaid eligibility and how the next steps will continue. So very important that we're encouraging our newcomers to keep that updated information with their government agency that manages Medicaid, and also encouraging follow-up with those next steps after they receive their notice. And refugees who are not eligible for Medicaid, they still will be eligible for RMA or refugee medical assistance for up to 12 months after their arrival. And for patients who are not eligible for either Medicaid or for RMA, we can, in certain instances, look for employer health plans or shop in the health insurance marketplace. However, this may not be an option for a majority of the individuals that we're serving. So we can also encourage information or provide information about our free health clinics or our federally qualified health centers. And of course, continuing to map our local services for our patients. This could mean our vaccine clinics, our one-stop shops, any health agencies who are aiming to fill some of that gap. Next slide. Okay. So in talking about filling the gap, the federal government and the Health and Human Services Administration did announce the Bridge Access Program for COVID-19 vaccines and treatments. So this is said to start in the fall of 2023, and we're going to be looking at two main purposes for this program. So number one, we're going to be supporting the public health sector. So that's your local health departments, your HRSA supported health centers, and they're continuing to provide free vaccines, treatments, and also the distribution of vaccines and treatments. The other area is also creating those partnerships and those relationships with pharmacies, that's small, large, independently owned pharmacies, in order for them to provide free, no-cost vaccines and treatments, and also pursuing these commitments made by our treatment manufacturers to support all of these efforts. And in the next slide, I can touch a little bit more about that. Okay. So this was pretty historic, but those treatment manufacturers that I'm mentioning, Moderna and Pfizer, did announce and suggest that continuing beyond the public health emergency, there would be the option for our uninsured individuals to receive free vaccines. So next slide. Oh, there we go. So what this is going to look like, it can be a bit vague, or there hasn't been a ton of coverage on what it's going to look like. But what we have been able to find is that they are still planning on selling their vaccines to healthcare providers when the federal stockpile ends. And keeping with the theme, that is set to happen in fall of 2023. So fret not, our insured individuals will be able to access those COVID-19 vaccines as a part of their normal coverage. And those private insurers and our Medicare and Medicaid programs are required to cover all of those shots recommended by the CDC. However, the federal and corporate programs, which we're looking at now, the Bridge Access Program, is where that gap for the uninsured and underinsured individuals is going to happen, or where they're going to be filling that gap. So we still have a lot of questions, like I said before, but with those questions, we do have some great resources, so we can go to the next slide. So to plug a little bit here, MCN does have this wonderful, amazing, frequently asked questions blog, COVID-19 and migrant, immigrant, food and farm worker patients, which is available in English and Spanish. What we're hoping as we continue beyond the public health emergency, as we're still continuing to have more and more questions about COVID-19, about all of these processes that I've mentioned today, we're going to be conferring with our staff, with our clinicians on our staff as well, to answer some of those questions for you all. So this is available in English and in Spanish, and it can be found at the link in the PowerPoint slide here. Next slide. Okay, and to further support some of the work and the amazing work that you're doing in your communities, MCN also has the Vaccination is Communications campaign, which is fully editable. And this is to promote vaccination against COVID-19 in your communities, and very specifically to your communities. So these are available in print, social media, graphics, video, and a variety of different amazing templates that you can use. Next slide. So these templates
It looks like Esther froze. Sorry, everybody. I'm just going to go ahead and say these templates can be edited in PowerPoint or Google Slides, social media templates for creating graphics to accompany posts, and frames for profile pictures. And of course, we also have video templates in Canva that allows communities to lend their own voices to vaccination efforts. So as Esther was mentioning, these are totally and completely editable. You can insert any picture or photo that you want, and you can completely modify this to your community or your
Okay,
population.
I think I'm back.
Yes, you are back.
All right, I'm
go
so
for it, Esther.
sorry. At
No
least it didn't
worries.
happen in the middle. Yes, so fully editable materials, we can take any variety of the materials that we have that I mentioned, print, social media, any of the templates, and also video. Take those, they can be edited in our PowerPoint and Google Slides. We also have social media templates, and also these video templates, which can be utilized in Canva. And I will also add that we have these amazing support and how-to videos for editing every single item that we are offering for free. They can also be translated into any of your language of desire. So yes, that was my whole spiel. Thank you so much. And I apologize for the technical difficulties. I will hand it back over to Marta.
Thank you, Esther. We're going to go ahead and go to the next slide. So here is our evaluation. So as you guys are completing your evaluation, we're going to go ahead and field some questions. So I have a question here from Javier Mejia. I'm just going to go ahead and read it. Muchas personas relacionan enfermedades de aparición después de la vacuna, por ejemplo, diabetes, cáncer, ceguera, neuromialgias, etcétera. ¿Tendrá relación? Do you want to field that question?
So Martha, you want me to handle that question?
Please, Ed, if you could.
Okay, sure. And I wrote a little something in the chat about that. I'm going to put my camera on just so everybody sees that it's really me. You know, there have been all kinds of crazy things people have said, like blindness and cancer and all kinds of horrible things with vaccines. The reality is that these are very safe vaccines. They've gone through stringent sort of trials to make sure they're safe. It's also a type of vaccine. We're no longer giving live vaccines. You know, the mRNA vaccine is a technology that's taken a couple decades to discover and perfect, and it's extremely safe. Now, the myocarditis was the most common, although extremely rare, side effect that we were worried about. Very, very few other side effects. No evidence of any sort of disabilities in children or babies. You know, the vaccines have been, for a long time, people have worried about autism and all sorts of other side effects that have never, ever been proven to be a side effect of a vaccine. So I think most of these things you're hearing are not factual, that when, especially in a vaccine that have been given to tens of millions of people, we would know if there was significant side effects. So I think most of these concerns are overblown. Now, people can have rashes, people can have headaches, people can get Guillain-Barré. That was also a question that came up. Guillain-Barré is this unusual reaction to both viruses and vaccines. Again, extremely, extremely rare, but has always been a side effect that's a possibility. Guillain-Barré is when you get some paralysis, numbness. They usually start at the feet and moves up to a point where a person can actually be paralyzed from the waist down. Most people with Guillain-Barré recover completely. Rarely it leaves with some numbness or some paralysis, but that's rare. So it usually is self-limiting. If you get Guillain-Barré after a COVID vaccine, that's a relative contraindication to ever get another COVID vaccine. If you had Guillain-Barré from a viral illness, then it's kind of questionable. but most people would be very careful in giving a vaccine to somebody that had a history of Guillain-Barré. So if somebody had that history, then it would be a decision between the provider and the patient to decide whether it was worth it or not to attempt a vaccine. I think it would depend on how dangerous getting the infection would be. I hope that long-winded explanation was good enough, Martha.
That was very clear. Thank you, Ed. There's also a question from Denise, and I believe there is evidence of toddlers less than 5 years old that received the vaccine and had any developmental issues. I think she is asking if there is evidence.
Again, those things have been out there in the lay media and in popular media, but not in the medical literature. It's never been shown that toddlers had any sort of developmental delay if they got a COVID vaccine.
Thank you, Ed.
Esther has her hand up. Go ahead, Esther.
No.
We can't hear you. Sorry.
Esther, did you not have a question?
Microphone is working. Yep, there it goes. Can you hear me now?
Yes.
Yes, we can hear you.
Okay. I know that Dr. Laz, our Chief Medical Officer, has mentioned previously that while there haven't been developmental issues with toddlers receiving the vaccine, they're starting to see that at times if the mother was pregnant and had COVID-19, the infection while pregnant, that now they're seeing some developmental delays or issues after the baby is born. So I did want to point that out, that the infection at times will be or is still a larger harm to the infant and to mom as well.
You're absolutely correct. Thanks for pointing that out. There's been a lot of issues with pregnant women who got COVID and real concerns about that. Also, some pregnancy losses early on in pregnancy with COVID. So pregnancy and COVID does not go well. So it's much better to vaccinate pregnant women than have them get the actual COVID. Thanks for clarifying that, Esther.
Thank you, Ed and Esther. We have a question here. What are the recommendations for testing healthcare workers if they have symptoms?
You know, it's still back to if they have symptoms, they should be tested. So healthcare workers still should be tested. In most states now, including New York, where I live, it's no longer required that they be vaccinated, healthcare workers. But any healthcare worker, it's kind of like during flu season. If you're symptomatic from the flu, you should be tested and you shouldn't go to work. So if you're symptomatic and you think you might have COVID, then you should be tested. And if you're positive, you shouldn't go to work. So that's why healthcare providers, especially, because they are oftentimes around highly susceptible, immunocompromised individuals, and they don't want to give that infection to their patients.
Thank you, Ed. Let's go ahead and move on to the next slide. So this is just letting you know that you can access our latest resources, get live updates from the field, attend our near trainings just by going to our website, www.migrantclinician.org. And you can also check us out on the social media platforms. Let me see if there are any other questions here. If you have a question, go ahead and raise your hand and we could unmute you so you can ask your question. And we had a question that came in earlier that I don't know if you know the answer to this one. It came from Maria Maldonado, and she asked if the bivalent vaccines exist in Mexico. I don't know if you know that, if you are aware.
I think somebody put in the chat that it did exist in Mexico, the bivalent.
Oh, okay, I'm sorry, I didn't see that. Thank you.
I think somebody said they had family members. But I cannot quote that myself. But the WHO has had it available, so I would think Mexico would have that available.
Thank you, Ed. Are there any other questions? Anything that you guys are not sure about? Anything that was unclear?
There is a question I'm just reading now. How long do COVID positive healthcare workers have to stay away from work? You know, this has always been kind of a debatable thing, at least 5 to 10 days, at least 5 days. And then the question is, do you have to test negative before you go back? And that's been very controversial because the virus can stay around and actually not be infectious. So I would say you have to at least have had no symptoms. If you test negative and been at least 5 days, then I think you can safely go back. If you're still symptomatic at all and still testing positive, you definitely should not go back. If you are at least asymptomatic for at least 24 to 48 hours, even if you're testing positive and it's been at least 5 days, then I think it's up to you and whoever your supervisor is, whether you should go back. And it should be on an individual basis at that point in time.
Thank you, Ed. I'm just taking a look to see if there are any other questions that we missed here.
There is a question about the evaluation. Did you see that one, Martha, in the Q&A?
Oh, I didn't. Hold on. Oh yeah, I'll stick the evaluation link in the chat right now so you can just access that. And here's a question that just came in from Liz. I have MS. Can I get a second bivalent if under 65? That's a great question.
Yeah, that's the one that's very controversial. So if you did not get the first bivalent, yes. If you got the first bivalent after September, if you got any booster after September of 2022, then that was a bivalent. And if you're not immunocompromised and under the age of 65, then you don't need to get it. If, however, you've never gotten a booster since September of 2022, then it's okay to get the one bivalent because you were eligible then. I hope that clears that up.
Thank you, Ed. Is there anything else that anybody wants to add? All right, I'm just going to give you guys a reminder that later today, I will be sending you all a follow-up email. In the email, you will find the link to the evaluation, the link to the recording, and attached to the email, everyone will get a PDF of the PowerPoint presentation. And if there is nothing else, if there are no more questions, I'm going to go ahead and thank you all for joining us. And we hope the information that we provided you is useful. Thank you, Ed. Thank you, Esther, so much. And like I said, be on the lookout for a follow-up email from me. Oh, and thank you to our wonderful translators. We appreciate what you do. We know it's difficult, so thank you very much. Have a good day, everyone.